Welcome, everyone. Thanks so much for joining us today. My name is Dr. Louise Ivers. I'm the director of the Harvard Global Health Institute, and it's my pleasure to welcome you to the very first event in our new Global Health Research and Innovation Speaker Series. This monthly series is designed to showcase the latest advancements in global health research with the goal of fostering dialogue and elevating innovative solutions that can improve health outcomes worldwide. So thanks for being here today, and I invite you to mark your calendars to join us at this time on the second Tuesday of every month for more speakers and discussions. Our session is being recorded today, and it'll be made available later on our website and YouTube page. And we will have time at the end to take your questions. So please, if you have questions for the speaker, go ahead and use the Q&A feature in the webinar at the bottom of your screen. So today, I'm absolutely delighted to be joined by Professor Milind Tambe. Professor Tambe is the Gordon McKay Professor of Computer Science and Director of the Center for Research on Computation and Society at Harvard University. Concurrently, he's the Principal Scientist and Director for AI for Social Good at Google Research. Professor Tambe's work focuses on advancing AI and multi-agent systems for public health, conservation, and public safety, with a track record of building pioneering AI systems for social impact for more than 15 years. Professor Tambe and his team have been focused on AI for social impact, deploying end-to-end systems in areas of public health, conservation, and public safety. I'm absolutely delighted to pass the microphone to him now. Please, Professor, take the floor.
Thank you so much. Thank you for that very kind introduction. And let's get going. So over 15 years, my team and I have been focused on advancing AI for social impact, focusing on topics of public health and global health, conservation, and public safety and security. Key challenge is how to optimize our limited intervention resources. One major lesson that we've learned is that social impact and AI innovation go hand in hand, something that you'll see throughout this presentation. Today, I'm absolutely delighted to talk to you about our recent work in AI and public health. The outline here, excited to share with you recent work on maternal and child health with world's two largest mobile health programs, MMitra, which is based in Mumbai in India with 200,000 beneficiaries or mothers enrolled, Kilkari, an all-India program where 3 million beneficiaries, mothers are enrolled in the program. I'll also spell out the implications of the work we've done for other public health challenges. Additionally, I'll talk a little bit about our work in HIV prevention in Los Angeles with youth experiencing homelessness. So let's begin with the MMitra program. The motivation here is the maternal health crisis we face today. The UN Sustainable Development Goal for 2030 says that the maternal mortality ratio, mothers dying during childbirth or soon after, should be below 70 per 100,000 live births. Well, where we are today, Western Europe, the numbers are significantly lower. So the dashed line is the UN target. In United States, numbers are rising, but still below the UN target. But worldwide, if you look, the numbers are significantly higher than the UN target. Today, our focus will be in India, where the numbers are declining, but still higher than the UN target. We've been very fortunate to be working with a nonprofit called Arman, which is active in 20 states in India, is working with 41 million beneficiaries. And this is a large-scale NGO. We've been inspired by the founder of Arman, Dr. Aparna Hegde, who points out that pregnancy is not a disease, childhood is not an ailment, dying due to a natural life event is not acceptable. I met with Dr. Hegde at a Starbucks in Mumbai in the summer of 2019, and inspired by the important work their organization does, decided that me and my research group could focus in assisting them in the work that they do. We decided in collaboration with Arman to focus on their MMitra mobile health program for new and expecting mothers. So harnessing the fact that cell phones are very widely available, this program provides a weekly 2-minute automated health message to mothers who register. From the time they register to the baby being 1 year old, every week there's an automated 2-minute health message of this form. For example, this is a small snippet of a message for you and your baby to be strong, you need lots of iron, and it goes on. 141 such messages are delivered to mothers from the time they register to, as I said, the baby being 1 year old. And 2 million beneficiaries have benefited from this MMitra program. Arman has shown through randomized control trials that mothers who register in the program, who listen to this 141 messages versus those who don't, benefit significantly in terms of their own health and the health of their babies. For example, 30% increase in infants with triple birth weight at the end of the year. So where do we as AI researchers come in? Unfortunately, 30 to 40% of beneficiaries may become low listeners over time or drop out of the program. And to understand why, it's important to note that 95% of the families who are enrolled in this EMITRA program have their income below the international poverty line. So there's a lot of pressure. So what can we do? Arman has this call center from where call center workers, health workers can give limited number of live service calls to persuade these mothers to not drop out of the program. But the population that is served is large and we have limited resource. Again, the challenge of limited resources that I mentioned earlier. To understand this better, consider the overall problem. We have 200,000 beneficiaries who have registered. Automated health message goes out to each of these beneficiaries every week. However, live service call can be only made to 1,000 of these 200,000 beneficiaries to persuade them to stay in the program, to keep listening to messages. Which 1,000? So as to maximize the total number of health messages that are listened to. To consider this even further, let's take this very simple illustrative example. A single health worker with 5 mothers under her care, 4 shown in red, have not listened to a health message, whereas 1 shown in green has listened to a health message last week. She has to decide which 2 mothers in this case may I call. So supposing she calls the first 2 who are shown in red. This is a live service call. She persuades them to start listening to health messages. They turn to green. 1 other mother on her own turns to green. Now she has to decide next week which 2 to call. Supposing she calls the 2 who are shown in red. This turns out to be a bad choice because those in red remain in red. They don't start listening. And in fact, those who were green also turn to red. The point here is that there's a challenge in choosing the 1,000 beneficiaries. A live service call may not change a beneficiary state, and beneficiaries may change state on their own. So how do you choose the 1,000? We turn to a model called restless bandits to prioritize K 1,000 of the N 200,000 beneficiaries. Each such individual in a restless bandit is called an arm of the bandit. Now, for those who may not be familiar, in a restless bandit, each mother will be modeled via a Markov decision problem. So a mother might be in a bad state. She has not listened to a health message, or a good state. She has listened to a health message. And there's a transition probability of going from a bad state to a good state. We can take actions like intervening by a live service call or not. And now we have transition probabilities. If we intervene, then the probability of going from a bad state to good state is 0.8. While if we don't intervene, the probability of going from bad state to good state is lower, 0.2. This is how we represent the behaviors of a single mother. In reality, of course, there's 200,000 of these mothers, so 200,000 MDPs, 200,000 arms, and you have to choose 1,000. 200,000 choose 1,000. This is a very complicated problem. The way we solve it is by computing what's called a Whittle index. Informally, it's computing the benefit of the intervention on the mother. For those who are interested more formally, it is the infimum subsidy we offer to us in non-intervention action, a passive action in a state such that the Q value becomes equal to the Q value of the intervention action. But mainly what it is doing is ranking all of the 200,000 mothers based on the impact of the intervention. So we choose the top 1,000 where the impact of the intervention is the highest. There is no out-of-the-box algorithm available to compute the Whittle index, but fortunately we had created one in 2016, which we used to compute the Whittle index. So now we can choose the top 1,000 beneficiaries, but we do not have the transition probabilities. And here we use machine learning to predict the behaviors of these mothers. We have a lot of data from previous beneficiaries, features for these mothers, age, income, education, and their engagement sequence. The mother was in a bad state, got a live service call, remained in a bad state service call to a good state, etc. So based on all of this data, we can learn a mapping from the mother's features, age, income, education, to the probability of transitioning from in different stages. So when a new mother walks in, given her features, age 26, income 5,000, education 8th grade, we can predict the probability with which she may go from bad state to good state, etc. So now we have the MDP representing the mother behavior, and then we can choose the top 1,000 mothers using our Whittle index approach. We call this a two-stage approach because we first maximize learning accuracy by choosing on average using past data, and then separately optimize by computing a Whittle index. Now it's time to test this approach in the field, and we did so with 23,000 beneficiaries. This is the first large-scale application of this restless bandit model for public health. These were divided into three groups: 7,667 in the restless bandit group, 1/3 in the round-robin group, 1/3 in the current standard of care group. Remember, each beneficiary in each group got an automated health message no matter what. What changed is who got a service call. We selected 225 mothers each week for a service call, that is pulling 225 arms of the bandit. And this was done for 7 weeks. In the round robin, it was the first 225, then the next 225, then the next 225. In our restless bandit AI group, the ones who got a service call were the ones with the highest Whittle index. And now it's time to check how many more health messages were listened to compared to the current standard of care where no service calls were made in each of the groups. And here's what we find. On the x-axis are different weeks. On y-axis, cumulatively, how many more health messages are listened to. Blue is the restless bandit group. Orange is the round-robin group. We can see that with the round-robin group, there's hardly any improvement over current standard of care. But with the restless bandit group, 600 more messages are listened to. What do we learn here? It is important to optimize service calls. If we just do service calls, live service calls using round robin, for example, there's hardly any improvement. And in fact, we can show that the restless bandit group cuts by 32% dropout rate compared to the current standard of care. So this was our first result. We're excited by it. But then we realized that we can improve upon these results using what we call decision-focused learning. Remember, I talked about this two-stage approach where we first maximize learning accuracy on average across all mothers, and then we choose the top 1,000 Whittle indices. However, maximizing learning accuracy on average across all mothers' behaviors doesn't lead to selecting the top 1,000. We really need to focus on the ones that we're about to select. And that's what decision-focused learning does. It focuses machine learning accuracy towards the ones who are close to being selected, so we can choose the right mothers to call for via our service call. I'm going to not have time to go into details of decision-focused learning, but we ran a second field trial with 9,000 beneficiaries. 3,000 in decision-focused learning arm, 3,000 in the two-stage or previous machine learning approach, and 3,000 in the current standard of care, no service calls going up. If you look at predictive accuracy on average, two-stage is better. But if you look at actual deployment performance, if we did live service calls, we find that with decision-focused learning, there are far more messages being listened to. The point I'm making is that it's not important to just optimize predictive accuracy. We have to focus it towards the actual decision that we are going to make here. And so decision-focused learning and restless bandit is what we have deployed with Arman in a system called Saheli. It means a friend in Hindi, but it's also an acronym. This is just to tell you, we worked incredibly hard to come up with this good acronym. We have deployed this system since April of 2022. We have served more than 330,000 beneficiaries using this system. It has prevented 30% of drop-offs compared to current standard of care. And for the bottom 25 percentile of listeners who are listening very little, content exposure has more than doubled, 130%. That means more mothers are listening to taking iron and calcium supplements and so forth. Neha Madiwala, who's the research director at Arman, points out that the AI model has been very effective in identifying women experiencing exceptional difficulties, including miscarriages and so forth, and prioritizing them for service calls. In fact, this has led to more satisfaction of the call center workers because they can direct these women towards counseling services. We've also done a follow-on study to look at, does higher listenership lead to improved health behaviors? We have a survey of 15 questions looking at improved knowledge of taking care of self and baby, like what are you doing or eating for your health after delivery, and found that higher listenership has generally led to improved health behaviors, although a larger study is ongoing at present. With all of this, Dr. Aparna Hegde in this YouTube video, you're welcome to look at it, AI for Social Good in partnership with Arman, points out that we are able to reach out to more and more women each week and get them back into the fold and save lives because of AI. I'm now going to play a short video of one of the beneficiaries who was interviewed in this video.
मी तो फोन नव्हते ऐकत पहिला, त्याच्यानंतर मला त्या ताईंचा कॉल आला, त्या घरी आल्या, मला समजवलं हा कॉल घ्यायला पाहिजे, तुझ्या पोरांसाठी चांगला आहे हा. मग तेव्हा मी कॉल घ्यायला लागले आणि ते कॉल ऐकून खूप बरं वाटतं की कोणीतरी घरचंच मला कोणीतरी समजवायला येतंय. मग जसं ते कॉल ऐकते मी तसंच मी माझ्या पोरीचं संगोपन करते.
So I have grown up in Mumbai. Marathi, which is what this mother is speaking, is also my mother tongue. So this brings a lot of satisfaction that our AI research is actually benefiting these mothers. Let me talk about some of the ongoing work based on what first generalizing this restless bandit model for other health challenges using large language models, ChatGPT, etc., towards generalizing these RMAP models even more. And then briefly about the Kilkari, the largest mobile health program for maternal child and health in the world. So let's talk about other challenges. For example, tuberculosis. By the pictures in the corner of the students who did the work. Tuberculosis prevention, which tuberculosis kills 1.3 million people worldwide. Treatment for TB is to take 6 months of pills. Now, I get tired if I'm asked to take pills for 6 days. 6 months is a long time, and patients drop off of treatment, not only bad for them, but it also leads to drug-resistant bacteria. So once again, we can imagine a call center from where calls go out to remind patients to take their pills. So for example, in this case, with hundreds of patients under her care, this particular health worker may only call 3, in this case, patients. 2 of them say, I have not taken my medicine last night. 1 of them says, I have taken my medicine. So she reminds them to take their medicine and this decides who to call tomorrow. This problem is very similar to the problem I showed with maternal and child health, except that the state of the patient is not known in advance. We don't know if they took their medicine or not. This is a challenge of partial observability. There's a different model, partially observable Markov decision problem that gets used, but we have devised newer fast algorithms to solve these POMDP-based restless bandage. Another challenge in our paper in JMIR Diabetes that was just published, diabetes, of course, affects more than 540 million people worldwide. There are now these digital adherence programs to log exercises and meals and blood sugar for patients, but patients may drop off of adherence. And once again, there's a challenge of who should health coaches call or text. Challenge for restless bandits to allocate these limited resources. And we have devised this equitable restless bandits to distribute resources equitably across different groups of arms to prevent disparities between groups using objectives such as max NASH welfare. Now, so far, I have talked to you about TB has a separate restless bandit with a separate objective. Diabetes has something different. Maternal and child health, a different restless bandit model. Instead, if we can give nonprofits a pre-trained, instructable restless bandits that they could command using natural language, that's what we want. So then nonprofits could, or government agents could do a variety of tasks using restless bandits to change prioritization based on what they want. And so large language models can be brought to bear to shape the restless bandit prioritization, to choose which top K beneficiaries. In the case of Arman, for example, they may want to say, okay, give more attention to beneficiaries who likely work early in the morning or late at night. If you want to give this command in natural language, in fact, we've implemented a system using LLMs. So they can do this via an LLM, in this case, Gemini. We can then get the restless bandit model to change the top case selection to prioritize the beneficiaries that Arman wants in this case. This is all currently being done in simulation as a demonstration. And we show that a human given this command versus an LLM given this command can reach roughly the same level of performance in simulation. So this is just to demonstrate the power that LLMs can help us with. And hopefully what this means is we can now allow more nonprofits to start using these tools. And this is something we are very excited by for future work. Finally, with respect to Kilkari, the largest mobile health program I mentioned, run by India's Ministry of Health and Welfare, Arman is helping scale up this program. 30 million mothers have benefited in total from Kilkari. It has 3 million active subscribers. Our focus with Arman in the collaboration is to again prevent beneficiary drop-off. One key challenge in Kilkari is that there's no demographic features, no age, income, etc. is available to us. So now we use time series to predict the next age. So for example, a mother in week 1 has listened to 40 seconds. In week 2 has listened to 60 seconds. In week 3 has listened to 10 seconds. Can we use this data to make prediction of how much of the message she will listen to in week 4? In fact, we've built such a system using this time series without any demographic features and in simulation with 4,000 beneficiary data from the state of Odisha, shown that our approach of intervention using a ratio, which is shown in this blue and orange bars. So an intelligent ratio that measures improvement in listening due to intervention compared to random intervention will lead to more listening behavior on part of the beneficiaries. So this is something we are very excited by to take next steps with Arman towards field tests. So this is something, again, an exciting future for us to scale up what we've done towards a very large number of beneficiaries. We've also worked with other nonprofits, for example, Help Mom in Nigeria. This is a paper we wrote on an AI-driven vaccination intervention optimization. And we're very glad after our paper was written in 2022 that Help Mom on their own has taken and deployed advisor and shown that in the Oyo district in Nigeria, that they have increased vaccination rates. So let me switch gears now to show you a different application of HIV prevention in Los Angeles of how AI could be useful. So this is work we did with youth experiencing homelessness in Los Angeles. There's 6,000, in fact, recent numbers show 9,000 youth who sleep on the streets of Los Angeles every night. The rates of HIV in this population are more than 10 times the rates of the normal house population. We can't reach all of these youth for HIV prevention knowledge. Instead, homeless shelters will bring in key peer leaders, educate them about HIV prevention, expect them to talk to their friends and their friends to talk to their friends, and in this way, information to spread in the social network. This is real face-to-face social network. This is not happening online. So the challenge is, imagine a social network. So this is friendship network. Each number here is a youth, and each edge is a friendship edge. And we have to choose key influencers, these limited resources, such that when we educate them about HIV prevention, information spreads in the network to maximize expected number of influence nodes. And this is a picture from one of the education sessions held by our social work colleagues for youth experiencing homelessness. Information is spread, we model as spreading via this independent cascade model. If youth C is educated about HIV prevention, their friend D will be educated with a probability of 0.4. And if D is educated, their friend E will be educated with a probability of 0.4 and so forth. There has been 2 decades of work in computer science on this influence maximization to choose the right peer leaders, how to choose the key influencers. All of that work assumes that the social network is known in advance. In reality, we don't have a social network of youth experiencing homelessness. How to choose these key influencers? So main contribution here was to come up with a newer algorithm that sampled a small fraction of the social network, say 10% of these youth, and then choose influences in a manner that maximizes influence spread. We built a system, it's called Change. It has this network sampling based on which it does peer leader selection. We ran an experiment with 750 youth. This was run with Professor Eric Rice in the School of Social Work at USC. 250 were in the Change arm, the AI arm choosing influencers. 250 degree centrality is this traditional approach of bringing in the most popular youth, and 250 in the control group, no influencers here. And we want to know at the end of 1 month and at the end of 3 months, is there any actual reduction in HIV risk behaviors? And what we find, this is work done, this first large-scale application of influence maximization to public health, work done in collaboration with 3 homeless shelters. And what we see here is in the end of 1 month, reduction in condomless anal sex change caused our AI system more than 30% reduction. Degree centrality, our competing approach or control group, hardly any change in reduction in this behavior at all. At the end of 3 months, degree centrality begins to catch up, but change is still superior. The point here is that this AI intervention makes this reduction happen faster, which is important because this is an HIV risk behavior and also because youth come and go in this population. We've also looked at other indicators, reduction in condomless vaginal sex, and we can see that this AI intervention from change is superior. Our collaborators are certainly delighted by this approach.
Beautiful way to kind of like marry this tech world with this social service world, like, and how we can kind of go deeper and impact young people and
I wanted to just show one slide on the work we had done previously in COVID-19 agent-based modeling. This is work done with Professor Michael Mina. The challenge, remember, this is spring of 2020. This is March 2020 when Dr. Mina approached us with this problem of doing agent-based simulations to compare RT-qPCR, the gold standard, with antigen-stress rapid tests, because at that time it wasn't clear which was the right way to do testing. So our paper in Science Advances talked about test sensitivity is secondary to frequency and turnaround time. That is to say, frequency and turnaround time that is provided to us by rapid tests is what we really need, rather than necessarily going for the gold standard RT-qPCR test. And this work received a lot of attention in the news media. And at one point, we were thrilled to see Dr. Fauci also discussing this work. And all power to Dr. Michael Mina on this, in this case, because what we provided him was a quantitative agent-based simulation result with which he could then argue towards acceptance of these rapid tests. So this hopefully gives you an overview of some of the use of AI for various public health and global health challenges. I'll end here by pointing out some of the lessons that we've learned very quickly. First, as I mentioned, achieving social impact and AI innovation goes hand in hand. We have to look at the whole data to deployment end-to-end pipeline. We are supposed to be swimming in big data, but often in our work, lack of data is the norm. Like social networks are not available, and dealing with it is actually the research. We've really focused on partnerships beginning to end with different nonprofits, governments, or local communities, and a lot of other lessons learned about partnerships. Most important among these is to not engage in any helicopter science where we go in, take the data within a community, publish a paper, sometimes being critical of the policies and running away, but to stay engaged for the long term for impact. So thank you for listening to me. That's the end of my presentation. If you wanted to get in touch with me, those are my coordinates. Thank you.
Wow, thank you. What a tour de force, touching on so many parts of the applications and really giving us a lot to talk about. So I'm going to encourage the audience to keep putting questions for us. We already have some. And so thank you for that. Maybe I'll start with a little bit of what you had towards the end of your talk there, and a question we had about what advice you might have for researchers or those involved in tech and new tech. How is a good way to partner with nonprofits, especially in low resource settings? What kind of advice do you have for us and for our audience about that?
I think the most important is to approach these nonprofits with humility, particularly if you are a tech researcher, because they are experts in their domain. Maybe we know a little bit about AI, but we don't know enough about their domain. And to engage in a partnership from beginning to end, meaning that it's not only to go, get the problem from them, get the data, go into back, perhaps in our ivory towers or what have you, to develop a solution and say, here's a solution, but engage in that partnership throughout. So I often say it's all about partnerships, and partnerships. That's the key to really making these AI for social impact approaches work in the real world.
Yeah, thanks for that. You really have to be, if you think about partnership, you have to think about, okay, it really is supposed to be that both parties have something to contribute and be willing to listen and to stay humble. Some of the questions, we had a couple of questions came in about that I put in the category of inclusiveness and accessibility. one person wants to know, how can we think about the future of AI and making sure that people with disabilities are included? And someone else was asking a little bit about access to mobile devices and how that, how we should address that. And maybe I'll ask you to take those two things together.
No, this is very important. In this particular case, particularly as it relates to mobile, access to cell phones and things like that, the NGO Arman in this case actually is harnessing the fact that the mobile phones are available very, very widely. And that's the key here. And these are not smartphones, these are just, standard feature phone type. And so that's what they're harnessing. But for those who still can't afford that, then you would have to have a different layer of service, and that is important. And really, I mean, this also touches on issues related to bias in AI and inclusiveness in terms of making sure that, based on the data, that the results don't become biased in serving one part of the community versus another. And this is something that we have been very, very careful with in continually examining the results that we have to make sure, for example, in our data set, there's information about education and income and so forth. And so who are the service calls? Who are the resources going to? Are they being spread evenly across the different populations based on the features that we have? And we have shown that does happen. But that is happening just by chance in some ways. It's not guaranteed to happen. So some of the recent work is really trying to make sure that we plug in this notions of fairness in the system so that it is distributing resources, as I mentioned, for example, in the work that we are doing with diabetes, to make sure there are no disparities across the different groups that we have available. And so that's also a very important issue that we have to continually deal with.
Yeah, that's great. I was really struck by how, the use of this, as you described it, could really help advance equity, because at least if you think about equity, is not that everybody gets the same. It's that everybody gets what they need when they need it at the time they need it. And so with this application, you're really helping to identify where to put those resources to have the biggest impact. The other thing that struck me, and maybe I would not have thought about this so much 5 years ago, but is the opportunity for nefarious or misinformation. You're having these important and presumably well-vetted messages going to moms. How do we kind of vaccinate ourselves against, or can we, against the potential use of this type of technology for misinformation or disinformation in the health? Let's even focus on the health space and forget about the other types of spaces, political and others.
Right. No, I think, these are such fundamental questions that, particularly even the influence maximization work that we are doing for spreading information about HIV, one can imagine that the same techniques can be flipped to spread disinformation about, how to identify influencers. And this is a really important challenge in terms of, we are pushing this technology for good, for trying to have positive impact. So there are certain things that we've done to try to, as much as possible, try to protect ourselves or protect the technology. But in the end, this is in some sense, a really difficult challenge. Some of the, in the past, not with Arman, who we know very well, but with other organizations, we have had agreements that the technology that we supply them will only be used for the purpose that we have given it to them and not beyond. So these are, at least legally, we can sort of try to enforce these sorts of restrictions and things of that nature. Again, this is not anything related to the NGOs I mentioned today, but in other cases. But otherwise, I think, it's really this trust that we build up. It's really the partnership that I mentioned. That's what we are really relying on to make sure that, what we are providing is not going into the hands of some unknown, organization who just just contact us overnight and say, okay, here now, make this widely available or something like that. So but yeah, I mean, these are really deep questions about the future of AI and so on.
Yeah. Your video of the colleague working for homelessness was talking about how great this was complementary to the activities they're doing. And one of our audience members asked about the ASHA workers, which I understand are community health workers in India, and asking about how the tool could complement the work that those humans are doing. And so I'd love to get your reflections on, and perhaps this goes back to the question of partnerships too. How do we think about the collaborative endeavors that both community health workers and NGOs are doing to address maybe those who don't have access to technology? How do they complement each other, and how do you see that going forward in the future?
So no, this is a wonderful question. In another effort, this work is entirely, for example, the Kilkari work that I mentioned, which hasn't started yet, but is something we plan to do in the future, is predicated on the fact that we will be assisting the ASHA workers. So in some sense, it is their responsibility to ensure that they alert all of the mothers or whoever is under their care to listen to these Kilkari messages that come in. But given the number of people under their care, trying and going and talking to each one of them may be difficult. So what this AI system is doing is telling them, okay, these are the people you need to connect with. So it's trying to reduce the burden that they may have in their normal course of work. And in this way, kind of complement what they are trying to do. In another effort, again, in collaboration with Arman, the idea is, could we use large language models to assist in training these ASHA workers because basically they have some training manuals. So could they use the LLMs to ask questions of those training manuals and get responses? And in this way, kind of improve their ability to learn from these manuals and so forth. So our work is always trying to take the existing processes and then see how AI can make these existing processes with the existing people more efficient by, instead of calling people at random, you say, okay, now we'll tell you who to actually call. Or just selecting influencers by choosing who are the most popular will tell you with AI who are kind of better influencers. And so that's been the modality of our work. And so I think it is indeed trying to always partner and complement what is going on. But yeah, it's very interesting as to how in the future we can continue to have AI and human beings working together, because it's a interesting challenge for AI and the working with the human, because sometimes the AI may notice, because humans are not infallible, the AI may notice that the human is making recommendations that are probably not the best in certain circumstances, but the AI doesn't know enough. And so the question becomes, how should the two work together in order to make sure that the right decisions get made, and who has not necessarily always that one has an upper hand. What the AI says will always go, or what the human says will always be the last word. Those are future interesting questions to think about as well.
Yeah, and they seem like really existential questions for humanity and for the future. So it's really great to be talking with you about them. It made me think also about, you talked about, as you were presenting your research, maximizing the learning as one of the steps early in the presentation. How do we make sure that, if you think about the lack of data that can exist, certainly in some communities, sometimes those are the communities that we're actually trying to reach out to. Large language models are trained on some languages even more than others, speaking of English. And how do how do you think about that aspect, the data in part to AI, so that we make sure as we get into using it, that even it learned from a diversity of humans and a diversity of experiences?
It's such a fantastic question. This, we have been told again and again that we're swimming in this big data world and everything. But in most of these communities that we work with in this, particularly AI for social impact, is geared towards working with more marginalized communities, youth experiencing homelessness, for example, and others, where data is indeed very sparse. And so for my students, often the PhD that is earned is how to deal with the lack of data. And so Brian Weiler, who did his PhD work on this HIV prevention, his whole major set of papers were focused on how can we sample a small fraction of the social network in order to be able to pick the right kinds of influencers. And so this question of dealing with small data, sparse data, by sampling or by doing other kinds of, figuring out in other ways how to compensate for this lack of data is actually a very important research question. And that's something, at least in this area, is a central question. And that's often where students earn their PhDs. And so often I say, okay, just sort of looking at the lack of data is often where the research question begins. So it's a important feature of these problems. It's not something that, it's like, you can't go to a domain like this and just say, there's no data, we can't do anything about it. I think that's just not the right approach, because most of these problems then will become inaccessible to AI. I think we have to assume going in that we are not going to have the right kind of data. It's going to be noisy, it's going to be sparse. And then how do we build AI techniques despite these biased data that may exist or sparse data that may exist and so on. Yeah, I mean, it's a fascinating question, and hopefully in the future we will get to a point where some of these inequalities in data and so forth will go away, but we're not there for now, for sure. And that's something that's...
So we have maybe 30 seconds left, but we had loads of questions. But what I can see is that people are very curious about AI for antimicrobial resistance, AI in radiology, AI. How could you advise non-experts in the area? Are there tools we could start to use, or we could experiment? What advice would you give to a non-expert and how to get involved in AI in their research in public health?
I think if you are a public health expert, for example, then I think that already is a huge asset, because you know the right kinds of problems. I feel like the COVID-19 work that we did, the fact that Michael Mina actually knew exactly what was the question to ask was important, because, yeah, I mean, we were excited. We are experts in multi-agent systems, agent-based modeling. We have been doing this for the longest period of time. We don't know what question to ask. We just, have some tools that we can use. So being able to ask the right question, I feel, is already such a huge, important step forward. And now having this question in hand, I think maybe the first step is to find the right kind of partners in the relevant AI space who may be able to help in trying to answer that question. And I'm sure there are people who will be very glad to help, especially if there's a massive public health challenge. I can tell you that when I teach classes and so forth, or when I go out and give talks, they're more towards the AI audience rather than, let's say, the public health audience. And there's so much of hunger, it seems, especially among the younger AI researchers, in terms of how can I use my knowledge for social impact, for social good. And the question for them is, where is the question? Because they don't know what could they do with this knowledge, and they are looking for the right kinds of partners themselves. So yeah, I think if you have a question in mind, and it's that I think is a huge step forward, and I would recommend trying to find partners, just as for the AI researchers, I recommend, just go, find a local nonprofit in your area, try to see. I mean, it's not going to be easy, but try and connect. And that's the way to kind of get into this AI for social impact space, rather than just sort of imagining that there is a problem that, that we want to solve, and going after and providing a technological solution that nobody wants an answer to.
Yeah. Well, we're out of time, but this was such a fantastic presentation and talk. Thank you so much for sharing your knowledge with us. Thanks to all of the audience for joining us from all over the world. And I will drop the teaser that if you found this conversation exciting, please consider joining our annual symposium, Harvard Global Health Institute Symposium, on April 18th online. You can find the information on our website, because we're going to talk about this topic in more detail with you and some guests as well. Thank you so much for being our inaugural speaker. It was really fantastic, and we'll see everybody next month. Thank you.
Thank you so much for inviting me, and thank you to the audience for listening to me. Thank you so much. Bye.